Hey, clinical psych folks. So this is going to be a brief PowerPoint walking you through the third wave therapies, and I'm going to explain what that means more as we go through PowerPoint. Just for reference, the interesting looking gentleman on this slide is Stephen Hayes, who's the founder of acceptance and commitment therapy. And then the very distinguished looking woman is Marshall Linehan, who's the founder of dialectical behavioral therapy. So the three waves of therapy come out of behavioral therapy. So there are the three waves or stages of behavioral therapy. So the first wave is what we talked about a couple weeks ago. It is strict behavior therapy. You're just using behavioral techniques. The second wave is the cognitive therapies with behavioral components included. So your CBTs, your REBTs. The third wave is to incorporate acceptance and mindfulness into standard cognitive behavioral therapies. So this is the third wave. It includes things like mindfulness meditation and acceptance that the world's not always going to be great. So in terms of these therapies, acceptance and commitment therapy, it looks like we should call it ACT since we call everything else just by its letters, but Stephen Hayes insists that it is called ACT. There you go. And then there's dialectical behavioral therapy, or DBT. Now, I was trained in both of these. Excuse me while I wiggle on my couch here. And I like DBT quite a bit. I struggled a little bit with ACT, but I do think that it is helpful for certain clients. There's also mindfulness-based cognitive therapy, MBCT, and that has all three of these have a lot of good research behind them. So Stephen Hayes was raised in California in the 60s during hippie counterculture. Okay, that should give you some context for ACT. He had an interest in Eastern philosophy, tied it into psychological science. And he was not the first person to do this for mindfulness-based cognitive therapy, especially for depression. There's a guy who's wonderfully named Zindel Siegel. What a great name for someone who's incorporating mindfulness. And he was doing some of this either at the same time or before Hayes was. So the idea is we bring the ideas of acceptance and mindfulness into the existing, well supported by research, cognitive therapies. And it focuses on cognitive distancing. And he developed ACT in part because he had panic disorder and he wanted a way to treat it that made sense to him. Now, ACT believes that psychopathology or abnormality is caused by processes in your mind. So very similar to REBT or CBT. This is destructive. The way we're thinking about things is what's harmful to us. And then it argues that we struggle to alter unwanted private events, even when decreasing them. This is experiential avoidance. And then we are basically trying to stop our undesirable thoughts, but in so doing, we're just perpetuating avoidance of ourselves, essentially. And this leads to what is termed cognitive fusion. Now, one thing I should say about ACT is that Hayes and other people who are into ACT write in ways that are almost indecipherable, even to those of us with PhDs. So if you stumble upon ACT literature, just know you're not alone if you struggle to understand it. Okay, so some of the therapeutic processes that you use in ACT include consciousness raising. So you try to focus on what's going on right in the moment. And that way it sort of draws from ideas that Gestalt does, right? Choosing, you try to get clients to make active choices, make committed actions. And a lot of what ACT emphasizes is doing that in concert with your values. So it helps people figure out what their values are. Catharsis, so similar to psychoanalysis, getting things off your chest, and then counter conditioning, so mindfully observe and accept rather than fight. So whereas in REBT and CBT, you're going to dispute negative or irrational thoughts, in ACT, you're really going to get at, this is a thought I'm having. One of the ACT phrases is, a thought is just a thought. It doesn't have to control me. A thought is just a thought. The therapist acts as an experienced coach. helps the clients identify private events that are interfering with being effective in their lives. And again, values are a really important component of this, teaches mindfulness skills like meditation, and also acceptance skills. So the one time that I have used ACT very successfully was actually for a woman with obsessive compulsive disorder. And typically when someone has OCD, you would do a cognitive behavioral technique like exposure and response prevention. However, her OCD was entirely mental. And this can happen where people have mental checking or feel like they're going to do something horrible and they never do. And so ACT was actually really effective for her, which was great. Now we'll talk about Linehan, and I have actually had the fortune to see Linehan speak. Um, she is one of the smartest people you will ever see. There are videos of her on Blackboard. I highly recommend that you look at them. I've also seen Hayes speak. Hayes does a little more abrasive. So he was on a panel with a behavioral therapist and a cognitive behavioral therapist, and they were both sort of saying all these three things work, they're great, the research supports all of them, and Hayes was like, ACT's better than all of them. So there you go. So Linehan, still alive, 1943 to present, and she developed dialectical behavioral therapy, or DBT, for people who are chronically suicidal, and particularly those with borderline personality disorder, particularly those who engage in self-harm behaviors. So she drew a lot from CBT, and in fact, her original works talked about cognitive behavioral therapy for borderline personality disorder, but she also incorporated this acceptance and mindfulness. She sees this more as an expanded behavioral therapy rather than a third wave therapy. And she based this on the fact that she herself was perhaps borderline, certainly had a clinical diagnosis, and at that time they didn't know how to treat those folks, so she was just literally locked up in a padded cell. So if you can imagine someone with the symptoms of borderline personality disorder just being locked up with themselves, right? So she thought, there's got to be a better way to do this. On Blackboard, there's a great article about her from the New York Times where she talks about this. Now, DBT thinks that borderline personality disorder is the product of both genetic and social abnormalities. So there's some biological predisposition, perhaps genetic predisposition for heightened reactivity to emotional stimuli. And then people with this disorder are very vulnerable to invalidation of their emotions and thoughts of punishing, ignoring, and trivializing communications. And invalidation of their emotions and thoughts. Sorry, that came out sort of weird phrasing wise. This is really an idea that we have to look at what is the root, the stem, what is getting at, what is causing way down the road these behaviors. So a lot of what you do in DBT is also consciousness raising, trying to focus on the present, trying to be non-judgmental, because a lot of people with borderline personality disorder dissociate. It's one of the symptoms. Sometimes you have to literally bring them back to the present moment during session. Sometimes they also have experiences of trauma. A great percentage of them do. So sometimes you're working with that first. DBT is a lengthy process. Some of these other therapies we've been talking about, 20 sessions and you're done, right? DBT, the first portion of it, so getting them through the skills training group, working with an individual therapist, that is 2 years. 2 years to stabilize everything before you even start working on the underlying issues, which again is often trauma. But the idea is you've got to stabilize these folks who are self-harmers or have difficulties with identity or emotion regulation before you start delving into treating something like trauma. I did DBT while I was on my residency, and one of my clients had tried to kill herself 3 times in the month before she started seeing me by overdosing on her medication. So these are not people that are to be taken lightly. Some people sort of poo-poo this as, oh, they're trying to get attention from their suicide attempts. Like in any one of those attempts, she could have actually died. So that's not attention seeking. So choosing, so you talk to clients about becoming mindful and accepting distressing events, um, coming up with skills that they can do in these situations. They actually attend a separate skills group that's like a class that they do every week. And they work through that at least twice during their 2 years. And then they have why it's called dialectical behavioral therapy is it's this dialectic between behavioral change and radical acceptance, where Linehan truly believes that like two things that seem like opposites can really exist simultaneously. So one of my favorite things that she says is that our clients are always trying the hardest they can. That doesn't mean they can't try harder. The idea that two people can be right about a situation, right? Just from their perspectives. Therapists relate like healthy parents. You really have to set limits on emotional reactions, on boundaries. So when I first started seeing my client who had tried to commit suicide 3 times, I had a phone consult with her psychiatrist, and he was like, "Don't let her hug you. She'll try to hug you." I never would have anyway. I set guidelines and boundaries with my clients, but it was really sort of interesting where she had a therapist in the past, not a DBT therapist, who had like, cuddled her during therapy, so she had boundary issues. Yeah, you don't want to do that with any client, much less someone with borderline PD. Trying to help the patients get support within their own lives. And there are really 4 modalities of traditional DBT. So you've got your individual therapy one-on-one with your therapist. You've got that skills training group. Then you've got what's called phone coaching. So the client, when they're thinking of self-harming, calls up the therapist and says, "Hey, I'm thinking of self-harming, but I haven't yet." And the therapist says, "Okay, go get your manual from the group and let's go over what skills you could use in this moment." And then the 4th modality is actually that the therapist needs to have a consultation group or supervisory group. And the reason for that is, as you can imagine, doing this therapy, working with clients who are this intense, right, and this perhaps vulnerable, is really difficult for the therapist too. So the therapist needs to have support in place in order to do the therapy well. And so then the therapist is going to shift from parenting to teaching as treatment progresses. Here's mindfulness-based cognitive therapy. So this added that mindfulness component to depression, and it employs a lot of the same techniques, really focuses on that mindfulness meditation. So in terms of third-wave therapies, these can be formed in any format, as you can see. It'd be more difficult with kids, but even we don't do CBT with kids most of the time. Most of the time with kids, we're doing more behavioral things. Although there are adapted CBT things for kids. So for example, there's a therapy for anxiety for kids called Coping Cat. There's a little cat mascot. It's adorable. And then growing adaptations and applications to many disorders and populations. So for example, DBT has been translated to treating clients with eating disorders and substance use disorders, because a lot of the techniques you use within DBT can be easily translated. So one of the things you use in DBT is a diary card, where you have people keep track of when they're self-harming or other problematic behaviors. It's easy to switch that to binging and purging, for example. And then another thing that you do in session as the individual therapist is what's called behavioral chaining. So you have them talk about their problematic event, when they self-harm, something like this. And then you say, okay, what happened right before that? And what happened right before that? And what happened right before that? And you try to get all the way back to what actually set this off, right? So they can start to recognize it much earlier on, use those skills, and not have to self-harm in the future. So the emphasis is on teaching the client and the clinician the mindfulness skills. So some clinicians who are into these third wave therapies will go to mindfulness retreats, study with Buddhist monks, go to retreats where you're not allowed to use your phone or talk for the whole weekend. This, as someone who, can never quiet her own mind, sounds like torture to me, but some people genuinely enjoy this and find this very helpful. Now, in terms of effectiveness, ACT does better than no treatment and weightless controls, but despite what Hayes says, it's pretty similar to behavioral cognitive behavioral DBT. It's not magically better. DBT is really the treatment of choice for borderline PD. It is the best empirically supported treatment for people with borderline personality disorder, and MBCT really shows promise, especially for anxiety and depression. So in terms of future directions, this seems like something that will keep becoming more popular. I go to a conference every November called the Association for Behavioral and Cognitive Therapies. And a lot of the sessions now talk about this, talk about using DBT for things, talk about incorporating ACT ideas into things. So a big challenge, as you see here at the bottom, is this actually better than CBT? Are we adding anything by putting in that mindfulness component, which might be great for some clients, but might also turn some clients off, right? So like I had a friend in grad school whose research project that her advisor was working on, that she was a research assistant for, was to do mindfulness-based cognitive therapy for individuals who had had heart attacks and were recovering. So these are mostly type A guys, right, who just like didn't want to be bothered. And when they got them to do it, it actually worked really well, and actually improved physical functioning as well as mental functioning. But obviously you can have rejection of it by clients, and it's not going to do clients any good if they're not willing to engage. There's some great websites here. I especially recommend the Behavioral Tech Research and the Linehan Institute if you're interested in DBT. So a couple of the resources that you do have here is that you have many things on Blackboard. I'm going to share that with you here. And this is under videos and links, third way therapy. So you have the DBT PowerPoint that Kathy Babel of the VA used when she presented to my class a couple years ago. So that really walks you through all the parts of DBT. Highly recommend looking that over. There's a case study that's specifically DBT related. I found it's not Linehan's book, but it's a DBT skills book. So it goes through a lot of the skills you would do in that skills class. Highly recommend that you look at it. It's the entire book. So there's just a PDF you can take a look at. Here's that New York Times article about Linehan. Some great videos of Linehan doing therapy. And again, know that some people find her abrasive, but her style works really well for these clients. And I think part of why she can do this so well is because she has those lived experience, right? So some other examples of DBT, a documentary all about borderline personality disorder that talks a lot about DBT. There's a lot of ACT videos here as well. There's a trailer for a whole video series I had to watch when I was in grad school that I found torturous, but you might find interesting. And then you see some of Hayes talking or some of Hayes doing therapy. Those are really good. This one, the values and action one, I think is also really excellent. You see several of the different techniques here. And then I'm actually going to show you through Zoom this video of Passengers on a Bus, just a little bit of it, just because I think this really encapsulates how ACT differs from CBT. So hopefully this will pull up for us. Got to open it in a new tab.
I'm Tom. This is the story of my bus and driver. On the journey, I pick up lots of passengers, memories, thoughts, emotions. Some pleasant, some not so pleasant. Sometimes happy and tricky. Come this way again. Same. Bloody fig.
What a grumpy lot. Don't worry, driver. I can sort them out.
So in case you haven't picked up on the metaphor yet, the idea here is that your thoughts, these internal events that you're having, are just passengers on this bus you're driving, and that you're in control. And yeah, they're there, and yeah, it can suck when they're yelling at you, but you're the one who gets to decide where the bus goes and which of them you pay attention to. So you can see how your thoughts might change your behaviors. Again, that basic behavioral cognitive idea. And so here again, you make a decision, and your thoughts might sort of, your passengers on your bus might start to rebel, right? And the idea is that, again, you're still in control, and that you get to decide what you do. So that is an overview of the third wave therapies. I hope you found that enlightening. I know our book doesn't go into them in too much detail, so I wanted to make sure you had some context. Take care, and I will see you again via video.